Great, and thank you so much for inviting me to speak today. I'm also from Thomas Jefferson University here in Philadelphia. I hope everybody's enjoying their stay. I have no disclosures related to this presentation. Over the next 10 minutes, I'm going to take you on a whirlwind tour of liver disease. We'll talk about some of the sex differences in epidemiology and etiology, complications of cirrhosis, unique issues for women, and then discuss very briefly access to and survival with liver transplant in women. So the progression of liver disease is similar in both sexes. It usually starts with a normal liver being hit by some type of chronic injury. And this can vary from viral hepatitis, fatty liver disease. We'll talk about some of those differences. And over time, due to this chronic injury and inflammation associated with it, the liver will start to form fibrosis or scarring. And as this scarring continues to develop, and this is a wide spectrum, it can be very quick, within 5 years, taking up to 50 years to occur, cirrhosis of the liver can form. And that's when major complications occur, including liver failure, need for liver transplant, or the development of liver cancer, hepatocellular carcinoma. So what cirrhosis really is the late stage of hepatic fibrosis, the buildup of so much scar tissue, the liver now has this nodular appearance. And at these advanced stages, it's thought to be irreversible. Again, we're going to go through some of these common causes like hepatitis B and C, alcoholic liver disease, hemochromatosis, and non-alcoholic fatty liver disease, and how they can differ in men and women. But before we go forward, an important thing to remember is that although the etiologies may be different, the cause of the liver disease, the clinical course and treatment is usually the same. So let's start with alcoholic liver disease. And this is really almost like a public service announcement for women. It's something we should be talking to our women patients about. Women have a much more rapid progression of alcoholic liver disease with a shorter period of drinking and with less daily alcohol intake. There's been many studies that show this. I just quote one here that showed that persons who consume 28 to 41 alcoholic beverages a week, the relative risk of developing alcohol-induced cirrhosis was over double that in women compared to men. There's few reasons for this, and women have increased susceptibility due to higher blood levels, due to lower body mass, and also decreased gastric digestion of alcohol. It's also less frequently diagnosed in women, and that may be because women generally don't drink as much as men. Maybe it's not recognized, but something we really should be talking to our women patients about. The same is toxin-related liver injury, and really what I'm talking about here is drug-induced liver injury. Women are more likely to present with drug-induced liver injury, so from a medication or an herbal supplement, and they're also more likely to have a severe course. So in looking at data from the acute liver failure study group of over 1,000 patients that they had collected with acute liver failure from a drug-induced source, 67% were women. The thought is due to differences in drug bioavailability and metabolism, and a lot of this, the pharmacokinetics behind it is not well studied when drugs are going through the development stages. So something to be aware of, and as you're monitoring patients to know about this. Non-alcoholic fatty liver disease, this is really becoming an epidemic. You're probably hearing more and more about this. It was thought in the past that this was more frequent in men and happened equally in men and women once women met the most postmenopausal stage. There's been some data that hormonal replacement therapy and OCPs may decrease the odds, but this relationship has not been well shown. And although the studies have shown that maybe women have a decreased prevalence, we're not sure because some other collections of like the non-alcoholic steatohepatitis network has shown that there was a higher prevalence in this group. So something important. But one specific relationship I want you to pay specific attention to is the connection of PCOS and non-alcoholic fatty liver disease. We know that PCOS is frequently accompanied by metabolic complications like insulin resistance, which are the same causes of non-alcoholic fatty liver disease. So in your PCOS patients, you should be screening these patients, and the same goes for us in GI. When we're seeing a young reproductive age woman in the clinic with PCOS, or with a non-alcoholic fatty liver disease, we should be screening them for PCOS. And I just quote a study here where there was a 71% prevalence in those type of patients. And they seem to have a more severe type of this disease, NASH, non-alcoholic steatohepatitis. Autoimmune liver diseases. We were just talking about the connection of autoimmune disease in women, and this goes the same for talking about autoimmune disease in the liver. There's a much higher prevalence of primary biliary cirrhosis and autoimmune hepatitis in women compared to men. But important to remember on the flip side of this, some autoimmune diseases like primary sclerosing cholangitis is more common in men. So it's important to notice these differences. So fortunately, or unfortunately for men, I guess, cirrhosis in women is overall less common and associated with lower mortality. So that's good, but still a very important problem. Women represent a little less than 40% of all patients in the US with cirrhosis, and about 38% of patients on the liver transplant list. Again, I mentioned earlier, the complications are the same, and we're going to go through those. But a few of the different complications that you need to be aware of when having a patient with cirrhosis are metabolic bone disease and cancer risk. So main factors for bone loss in anybody with liver disease is chronic cholestasis and cirrhosis. But in women, they have the additional risk factors, including female gender, postmenopausal status, or steroid therapy if we're in autoimmune disease. So make sure you're screening your patients and treating them appropriately because they will have a major risk of this. Hepatocellular carcinoma is the major cancer that we screen for in patients with cirrhosis with ultrasound imaging every 6 months. This has a much higher prevalence in men compared to women, 3 times higher, but irrespective of this, women should be screened as same as men every 6 months with imaging. Now, although women have a lower prevalence of hepatocellular carcinoma, they are more at risk of other types of cancers, specifically in a woman with cirrhosis due to alcohol with related tobacco use. They're at an increased risk of lung, oral, esophageal, and laryngeal cancer. So important to be screening those patients and realize that they do have that increased risk. As for cancer-specific risk, there is no increased risk in breast cancer, primary biliary cirrhosis. This was something that was thought to be there in the past. No increase in GYN cancer, so just routine screening. Benign liver tumors are something you may come across in your patients. These are much more common in women, specifically hepatic adenomas, which have been associated with OCP use. So important to recognize because these can be pre-malignant lesions and something to be monitoring patients for. So we'll quickly go through a few unique issues: fertility, pregnancy, and contraception. There are a few liver diseases that are associated with pregnancy, like intrahepatic cholestasis of pregnancy. I'll just mention that these patients are at increased risk of developing chronic liver disease in the future, so even after pregnancy, they should be followed. As for fertility, in patients with decompensated cirrhosis, usually they have failure of ovulation and loss of fertility. But in a woman with compensated cirrhosis, they may or may not have preserved fertility. They are at a very high increased rate of miscarriage and perinatal mortality. So these patients need to be really watched closely in conjunction with a hepatologist. Portal hypertension is the main reason for this complication, and the most common complication we'll see is variceal bleeding. I'll just mention to you that in a patient with varices or a cirrhotic patient undergoing pregnancy, they do need screening for these varices, that they are at risk of hemorrhage, and this can be in conjunction with your gastroenterologist to plan the timing. Very quickly, I'll just say for contraception, really there's very little restrictions. In any female with decompensated cirrhosis, you should avoid any hormonal therapy. But in somebody with stable disease, there's really no restrictions, and especially with the new progesterone-only preparations, there's minimal hepatic effects. So feel free to be able to prescribe those to your patients. Intrauterine devices are also very safe for these patients. Now, I'm just going to end liver transplant. I think this is very important for us to pay attention to going forward. The Meld Score is the scoring system that we use to put patients on the liver transplant transplant list. We started using that in 2002. In the pre-Meld Score era, 2001, and then the post-Meld Score era, women are more likely in 3 years of being listed in liver transplant list to receive a liver transplant. They're more likely to die waiting for a liver or become too sick. And part of this may be due to the fact that they have lower Meld scores, because the creatinine is one of the major factors in the Meld score. And in women with lower muscle mass, they're obviously going to have a lower creatinine level. So it's a very imperfect system and something that needs to be looked at in the future, although survival is the same in both sexes. So take-home points: women are more susceptible than men to the toxic effects of alcohol, medications. Women with cirrhosis are at high risk of osteopenic bone disease. The main risk factors in pregnancy are variceal bleeding, contraception, same as the general population. Thank you.